How you doing, Steven?
Good. How are you?
I'm
Or
doing
you
well,
said
thanks.
good.
Sorry about yesterday.
Oh, no worries. I got your email, but I
Yeah,
didn't check
cool.
it till after the call.
I blame you guys because they were your patients that got sent in.
Things going pretty good so far?
Yeah, a lot of good leads. I'm actually just super surprised and impressed with how quickly everything started. I think we had more leads in the first 4 days than we had in like a month with the last people we were using. And I just got another one right now. So I was gonna start texting but I'm gonna let AI do its thing for a minute and then I'll jump on.
So I was going to ask how things are going, but that's fantastic. And I did see your question a few hours back, and then Greg said you're going to be hopping on here. So instead of, I'll see what the group says, but maybe this first 10 minutes is just allotted to anybody that wants to hop on and ask questions. In the last 15 minutes, I'm going to talk about interdisciplinary and delegated care models. But so specific confirmation callback scripts. So meaning the leads said yes, but you're calling them to confirm.
Yes.
Okay.
So what I meant by that is exactly that. So like
Okay.
they'll pick what time they want, and then I'm just going to call and confirm that they actually want that time, or if there's a better time that works for them, just because we only give a few options.
Yeah.
And then we book them in our schedule, and then I move them over on the back end.
So I'm going to see what the. Go ahead, Stephen.
Just some understanding. You're talking once the AI has booked the appointment and then the
Yes.
confirmation process.
Yes.
Like we helped, my wife and I helped design the conversational AI with Stephen.
Oh, it's great. Yeah. No, it's great.
Yeah.
I was just simply asking if there was something that other doctors have been using. We've not been having any trouble. I'm just trying to learn as much as I can from people that have more experience doing this.
I watched her let the AI book people on the weekend. Part of why we like it is because, and I was a little bit nervous giving up the reins as being a perfectionist in that
Yeah.
regards, but we let it do its thing. And then Sunday, she actually texts and looks at what it's booked. And if it's a conflict, sometimes it's a conflict, she'll text and say, really sorry, there's been a conflict at Tuesday at 9:30. Like she'll manually do it. Can we do Thursday at 9:30? So she just picks up the text and
Okay.
starts having a conversation for those who need to be moved around. I'm like, well, that's annoying. But then I'm like, it's only going to happen once. Once they become a patient, they're never going to have to deal with
Exactly. Yeah.
conflicts, right? They get conflicts all the time. So I've watched her converse just say, we've had a double booking. I'm really sorry. We have Thursday at 9:30. If the time worked, she goes, great, we'll see you then, and then sends the paperwork, which is our confirmation. We don't call anybody. We send the paperwork. We get the paperwork back. They go in the system, and then they get a reminder. If they've completed the paperwork and they get a reminder, our show rate's like 89, 90%.
Okay.
I don't call, but I'm not saying not to. 90% for me is good. And I think most people are in that range. If you can improve another 5, 10% by calling, great. I just find it bogs the front desk. So I can't help you with the script, but let's see what everybody else has to
Okay.
say.
Yeah. No problem.
Does that make sense?
Yeah, it does. Absolutely.
Any other questions, concerns? All good?
All good so far. A couple duds, but
Yeah.
Yeah.
what are you gonna
You're,
do? Numbers game. I get it. It's a numbers game.
Yeah, you're gonna get that. Somebody explained it to me like this: is you're interrupting them. Google, they're coming to you. Facebook, you're interrupting them. So when you interrupt them, you're gonna get a tiny bit of, I would say tire kickers, but you're gonna get a little bit of that. But in the end, like we've had months 30, 40 new patients, 25 to 30 of them have been great. And
Yeah.
those are 25 to 30 people that would not be in our office. So time will tell. This is a
Yeah.
good start though, right?
No, it's a great start. It's only been a week. I think it's a week tomorrow. We had one
Uh,
guy prepay for his next 6 visits yesterday, one of three. The other one, she's very skeptical with everything because she's been under care with physio, paying out of pocket with no insurance for about a year.
yeah.
So I said, why don't you I said, I will still give you a 10% discount if you want to try one or two to see how it's going. So I make you feel comfortable and you like it. The next four, we'll still give you the 10% discount if you want to prepay for the four kind of thing.
Yeah.
And she says, yeah, absolutely. I'm on board with that. Let me just see how that works.
The,
So
Steven, these guys are gonna kill it because they've got really good. Just listening to you the last few times, you got really good decision making skills and conversational skills. That's exactly right. A lot of people will be a hard like, no, this is the way that we do it,
yeah,
and it's like, well, we're bringing people into our universe. We're asking to come there. We have to be semi flexible. Do you have? Remind me, it's DC. You have PTs in there as well.
We have a new PT. We had our PT leave, so we have a new one starting this Friday.
Okay.
She's going to sit in with me. I have a 10 a.m. or an 11 a.m. new patient coming in for Shockwave. She's going to sit in on that, kind of shadow how we convert that patient. And then I'm going to start giving the PT everything. And she's really good at, from what I've talked to her about, she's really good at pushing the chiro side of things after the fact. So like, we'll take your shoulder.
So this is going to be, sorry to cut you off. This is interesting because our podcast is going to be on this exact topic. Yeah, this is exactly what it's about, because my clients have done it all, and I've seen the one way that I think you might be open to is the most profitable and the best for the patient. Stephen, is this a good time just to roll into that?
Yeah, let's start. This is a good segment.
So we've had the same question, Dr. Shot, is when I have clients, they'll say, should we give it all to the PT? I want to get my PT going. And what's really people are talking about is a multidisciplinary practice. So you have solo practice, multidisciplinary, and there's a thing called interdisciplinary. And that's what I've moved to, and I'm trying to move my clients to. So the solo practice is a DC or PT by himself, refers, does their own thing. The multi is we bring in disciplines into our office, but everybody kind of sits in their silo. The PT sees a new patient, the next first time the DC sees a patient, and then they might get cross-referred a little bit, and then the RMT sees a patient, and everyone exists in their own silo. And it's good. There's less interconnection, there's less communication when it comes to each patient. It's less profitable. It can be less profitable, and it may not be helping the patient to the fullest extent. The multidisciplinary, right? The interdisciplinary model is when a patient comes in and is managed by multiple disciplines at the same time, right? Let's say a PT, a physiotherapist, and a DC is in the practice, maybe an occupational therapist, psychotherapist, whatever. They're all working together for that one patient. Much more communication. Care plans are designed around the patient using all of the disciplines. And that's usually done by a clinical coordinator. I don't know if you're familiar with that, Dr. Rashad.
No.
Okay, so, and again, I'm happy to be challenged. People can throw this up in the Skool group who are listening to this. I listened to a dear friend who had a 35 practitioner clinic in Toronto, 35 to 40 practitioner clinic, run an interdisciplinary model like that. And they were helping a ton of people and billing, I think, $6-7 million. So this can be done. The interdisciplinary model is run by a clinical coordinator. Let's just say it's Dr. Rashad, for example. He's going to see every single patient that comes in. Going to do a 5-minute consult, 5-minute quick exam, and understand what the patient needs and which disciplines are needed to be brought in order to help the patient get well. The clinical coordinator would do that. It's the most highly skilled person in that clinic, 1 or 2 people that have the ability to think forward and think outward. In my experience, most of the time it's DCs with some experience that have the capacity to do that. And we'll give you an example. I'll throw it a shoulder, since everyone's familiar with shoulder and we have great shoulder ads. Let's say Steven comes in on a shoulder with shoulder pain, and I do a consult and exam, and he describes a shoulder problem as in here and a little bit in here, and sometimes it goes down there. And let's just say I'm very skilled at examining him and determining, yes, there's a soft tissue component, but as we know, there's most of the time, if not all the time, there's a spinal component, right? And maybe there's a psychosocial component, maybe there's an office ergonomic component, maybe there's hasn't had a massage in 6 years component, right? As a clinical coordinator, okay, we can then gather that information. And a lot of times what I'll recommend is on your intake forms, ask for patients' benefits. It's okay, like people don't like to do that. We ask, what is your benefits for chiro physio? So I can best plan your care. Stephen returns, if we're not treating on the first visit, I go, listen, Stephen, this is what's going on with the shoulder. In addition to that, you also have spinal misalignments, and I think posture is a big play in this, and your office workstation needs a look at. Based on that, what I would recommend is 12 visits with a chiropractor, 12 visits of Shockwave, a specialist to look at your ergonomics, and a set of massage. Here's your care plan. How does that sound? Right?
I do that.
So that's the most, so this is not just for you, it's for the other 50 or 60 clients who don't do that, who allow the disciplines to They shovel off people to other disciplines. And often, sometimes, I'm not saying this happens all the time, but physiotherapists, you give off to the physiotherapist, and 3, 4 visits later, the patient's out the clinic, right?
Yeah.
Think of how much time and money you put into advertising and time with Stephen and Greg and with me and all that kind of stuff. I highly recommend you think about doing what Dr. Rashad does, is 1 or 2 people in that clinic taking the majority of these consults and being able to artfully direct people where they need to go. So that's the clinical coordinator interdisciplinary model. And I also believe the care should be delegated. So there are some docs, Dr. Rashad, I don't know if you know this or not, that are actually doing their own shockwave and laser. I really highly recommend that we delegate. We delegate, we delegate, we delegate. Train somebody to do that. If it's not your PT, I would like to have a kin or a PTA, so physiotherapy assistant or kinesiologist that works under both or multidisciplinary, right? That's doing all of the modalities. We have one, now we've added a second because she couldn't keep up. So there's PT and 3DCs. So physiotherapists, 3DCs that are allowing this one kinesiologist to do all the modalities. Delegate, delegate, delegate so that you can move on and do what you do well. Adjust, examine patients. Those of you who are holding the wand yourself, please consider delegating that care. Does that make sense? Rashad, I know you do that already. Stephen, any questions?
Yeah, no, this is really good. It's making a lot more sense to me now as well. But I guess one question I would have is, we have had some clients coming on and they start just with chiropractic and then they go out and buy like shockwaves and stuff because just of the way they see how it could possibly be successful. Like, how does one make that transition? Like, let's say they're just solely doing chiropractic, so like they're like kind of like a solo yeah, they're just doing it themselves and they're just doing chiropractic.
So Dr. Rashad, what is your thoughts on that?
My wife's an RMT, so we started the clinic together. So that's where the interdisciplinary care came in from. Then we added on the PT. When we added Shockwave 5 years ago, it was because I actually hurt myself and I wanted to treat myself with the Shockwave. So that's how I got it. So to transition, there were a lot of other patients that could have benefited that I did transition into Shockwave therapy after that. And it was just a matter of saying, hey, we have it. Let's try it. Right? Faster results and stuff like that. But from going from a solo practice, it's a great investment. I would recommend it 100%. But how to do it is, I don't know.
The way that I look at it, Stephen, is if I was in solo practice, solo adjusting, high volume, people have soft tissue injuries. I don't care what practice you have and how subluxation based you are, they're going to have a shoulder problem, knee problem, and foot problem, whatever. They're going to have it. Now you can choose not, and Dr. Rashad, I think will agree with me. You can choose not to treat it, but you have the duty to refer out. You have to, that for the benefit of the patient. The problem with referring out is people don't want to do it. They got to go to another office. They never did it. They went down the street. He didn't like chiropractic. Like it was getting frustrating for me, right? So I think number one is how to do it is realize people are going to go for other things other than chiropractic. Okay, you have the right to say no, but you have to refer. However, you can probably do it better than anybody else around you. DCs, I think it's PTs, physiotherapists are great, but chiropractors have a different mindset. Wellness-based body heals itself, that we can do these modalities at a higher level. If you refer out, great. If you don't refer out, do it in-house. All right, because you can take care of people. I found my patient visit average went up when I added modalities. I had a high patient visit average, 70 to 80. That's how many times people would come in on average. One patient would come in to get adjusted. It's because if you can keep everything in-house, they trust you. Dr. Rashad, I think you'll agree, is if you can do it all in-house, they're going to stay and they're going to trust that you can take care of everything, right? So for those of you listening that don't know how to transition, do some research, talk to a colleague, someone that's got it. Most chiropractors are good. They'll open up their office doors to that. Look around, shadow somebody for half a day and pull the trigger, buy it. I did the same with laser. We bought it for our own self for some injuries we were having and realized, oh my God, if it can do that for me, and what can it do for the patient? So do some experimenting and then pull the trigger. You'll be happy that you did. One other question too that came up when the group was running out of benefits, I think Greg had talked, there's a few clients that are saying, well, patients are running out of benefits and they don't want to continue chiropractic after they've done all the Shockwave. And there's two things to say to that. Number one is your consult goal-oriented consult versus pain-based? because people will stick around for goals, not pain. Are you demonstrating the problem through your exam? Is your exam up to speed and demonstrating the problem to the patient? If those two things are in place, the next thing you can do is get another discipline in. Okay. If, I like to not, I just give the patients what they need, and I don't really talk money until they bring it up. However, adding a physiotherapist or a massage therapist or someone who has another discipline that can bill is an easy way to take care of that.
Yeah.
That makes sense?
Actually, we had another question. I think you guys covered it last week there with the price. And I know Greg reached out to somebody and asked him like how, since we're talking about like price and making that transition, his answer was pretty good. It was, I don't even think about it, right? Because it's if you're goal orientated to help that person get to where they need to go, I think price takes a back seat.
I think probably I might rub people the wrong way with this answer is if you're thinking about money, then that's the problem, right? So I had a colleague and a client fly up to shadow me. It was a couple of weeks ago, and his comment was, "You didn't eat," because I refer a lot to this Shockwave, even on the fly. Dr. Rashad, if someone's come in a chiropractic office and said I blew up my shoulder, or my shoulder's hurting, on the fly, I'll get them in and refer them right away. And I set up the care plan, and it happened 2-3 times that day. And he goes, "You didn't even go through finances." And I said, "Well, were finances an issue?" And he goes, "Well, no." And I go, "Well, then why would we bring it up?"
Like you're creating the issue at that point.
So it's a mindset thing. I go in thinking everybody can afford it until they tell me differently. Everybody values it until they tell me differently. And if they do, I'll have that conversation with them.
Yeah. No,
Make
that's
sense?
good. Yeah.
Cool. Anything else, gentlemen?
No, I think this has been super helpful.
Okay, awesome. Great. Dr. Shad, you need anything, you reach out. I'm super pumped about your guys' results, and just hearing you talk, I think you guys are going to absolutely crush it. So I'd love to hear back in a month and two just to see how stressed out you are about all the patients. So reach out if you need anything else. I'm curious to see what people have about scripting. I got nothing for you, but I'll keep my ear to the ground. Awesome. Great job. I want to hear in a couple of weeks that you're just crushing it. And Stephen, good job. We'll reconvene next Tuesday. Gentlemen, have a great evening.
Have a good night.
See ya.